Again, thank you everybody for having us here. We've really enjoyed it, and it's been a great symposium, great talks. I've really learned a lot. And so my task is to talk about the role of exercise in obesity management. And my read of the data is really, I think that you can outrun a bad diet, which is contrary to the sort of article that stirred up a lot of discussion by a group who is really promoting the high-fat, low-carb diet. And I think they pointed out what we've known for years. If you want to lose weight, you've got to modify diet. You can eat more in 5 minutes than you can burn all day. There aren't simply enough minutes in the day if you eat very high-calorie, dense foods. But I think a better question, which would have been much more appropriate for the British Journal of Sports Medicine, was to ask the question, can you diet away the risks of being sedentary? And I would say you cannot. Certainly, obesity has been of increasing concerns in the United States, and we've really seen an explosion of obesity rates since 1990. You know, we are all, I think, in the United States familiar with this scary set of maps showing the growing obesity problem in 1990, where no states had more than 20% rates of obesity, to 2010, where every state had at least 25% of its population being obese, and these numbers seem to just keep going up every year. And corresponding with that, during the same time frame, we've seen an explosion of diets. And in fact, it seems like most of the population at any given time, or at least half the population, is on a diet. Everybody is trying to lose weight. I think they all understand they're overweight. The problem is, how do you do it? And in fact, in the United States, the American Medical Association took a vote and said back in 2013 that obesity is now a disease, which I didn't think helped us much when you consider that over a third of adults and 17% of children, and in fact almost 2/3 of NFL football players, in one fell swoop now have a chronic disease. And the response in America was not to let's improve diet and exercise. The response in America is let's make them pay for bariatric surgery and expensive diet pills. We have no interest in changing people's diet and getting them to be more active. And I think it's created somewhat of a hysteria. And I think we've had enough of this. I think the world has now been sufficiently alerted to the global problem of obesity. We all know how fat we are. We've labeled our patients. We've stigmatized them. We've assigned lots of blame as to what is causing obesity, spent lots of money, and really we have gotten nowhere, as evidenced by the map showing increasing levels of obesity. And I think there is evidence that patients, and more importantly their physicians, are simply giving up on this campaign against obesity. And I found this study very interesting, looking at data from the National Ambulatory Medical Care Survey, looking at a period between 95-96 and between 2007 and 2008. A snapshot showed that during this period, the number of adults who were overweight or obese increased from 52.1% in 1995 to 63.3% in 2008. But in that same time period, we found that patients seen in 2007, 2008 had actually a 46% lower odds ratio of receiving counseling about their obesity, how they could deal with it, and try to improve their risk from being obese. More concerning, when you looked at patients who had chronic disease like hypertension, they were 46% less likely to receive counseling from their physician about diet and exercise, and almost 60% of diabetics were less likely in 2007 and 2008 to receive similar counseling. So to me, this is evidence that the campaign against obesity, as we're waging it now, is not working. And you know, what's the definition of insanity? Well, Einstein said it's continuing to do the same thing and expecting a different result. So I really think that we need a new and fresh approach to obesity. I think we need to understand that some patients just are not going to lose weight, and we need to give them permission to maintain that weight and still be healthy. And to do that, we've got to shift the focus off of BMI, and I think the place to shift it to is on to promoting physical activity. And I love the concept of being healthy at every side. That is, we should focus on the broader aspects of health, because we know dieting does not work. 95% of those who lose weight with a diet regain it in 3 to 5 years. So that is simply not a viable option for us. Continue to come out with the latest diet book, and you can't get 5 people around the world to agree on what's the most effective diet. How do we get these people to lose weight? And we also know that a change in BMI is not a measure of success of an exercise program. That is, whether or not you lose weight, the improvements in health are independent when you start exercising. You cannot simply look at the change in BMI. Really, there are many benefits way beyond that. Because the evidence tells us you really are better off being fat and fit than skinny and unfit. And said another way, a low level of fitness is a bigger risk factor for mortality than mild to moderate levels of obesity. And I think the important take-home message for our patients is that you don't have to change your weight to get the benefits of exercise. So let's just try to hold your weight constant. Let's focus on getting you more active every day. I think that's a much smarter strategy. And I say this because we've got study after study showing us that when you control for physical activity, increasing levels of obesity affect mortality in a negligible fashion. This study by Beth Barlow, looking at 3 different weight categories and measuring fitness, and you see that in every weight category, higher levels of fitness are associated with lower death rates. But if you hold the physical activity constant and scan across, the death rate changes negligibly. It really does not affect the death rate. Tim Church found the same thing in looking at patients with cardiovascular disease mortality, that when you hold the physical activity level constant, BMI does not change cardiovascular disease mortality. Steve Blair, in his classic attributable fraction study, showed us that low fitness was the biggest risk factor for mortality, outdoing not only hypertension, but also obesity, smoking, diabetes. And Karim Khan hilariously pointed out that if you put these all together into this horrible disease called smoke-a-diabesity, that low fitness trumped that in terms of being a mortality risk. Jonathan Myers, in his classic study from the Palo Alto VA, where he's got literally thousands of patients who have treadmill data, and went back into his database and he looked at patients with chronic disease and how they performed on that next treadmill, and he looked then at how it affected their mortality rates. And what he found with every chronic disease, patients who were more fit, who could go farther on a treadmill, had correspondingly lower relative risks of death than those with hypertension, COPD, diabetes, even in smokers. And again, he reproduced that same data in BMI in obese patients who were more fit, had much lower mortality rates. Steve Blair, in looking at his years of research from the Aerobics Center longitudinal study, looked at specifically which factors best produce mortality when you compare fitness versus fatness versus smoking. And the data there suggest that those with the lowest mortality are those who are fit, have a normal BMI, and don't smoke, not surprisingly. But interestingly, the second lowest mortality was found in those who were fit, had an elevated BMI, and didn't smoke. And the third highest, or the third lowest mortality, were those who were fit with a normal BMI and were smokers. And so based on this research, we should be focusing first on fitness, followed by smoking cessation, and third on BMI. But I think these are the big 3. We need to focus on all 3, and I'm not saying we need to exclude one or the other, but they all ought to be on equal footing. I also think it's important that we shift what BMI we're looking at. It does not make sense that we continue to pound this idea that the normal BMI is between 18.5 and 25. That is not supported by the data. If you look at the NHANES data in the United States, at every age category, the BMI that's associated with the lowest mortality is between 25 and 30. And in fact, when you compare what's termed a normal BMI between 18.5 and 25, really it's not the mortality is not significantly different from those with a BMI between 30 and 35. Now, these is data from those 25 to 59 age, and again, you see the BMI with the lowest mortality, but we found the same thing between age 60 and 69. And when you get above 70, really increasing levels of BMI don't change the mortality at all. And the best BMI as you get older is between 25 and 30. So I'm not sure why we've got this obsession with BMIs being between 20 and 25. So based on this, I think patients need to they deserve to know the facts. I'm fine with telling patients you got to cut back on the crap, but if you don't couple that with a message you got to get more active, you are simply not paying attention to the irrefutable evidence for the benefits of exercise and the primary and secondary prevention of all these diseases. We've talked about this ad nauseum. We all know what a powerful medicine exercise is. So with that as a backdrop, I just would again ask everybody to consider a worldwide exercise prescription initiative. Every patient, every visit, every treatment plan ought to include a prescription for exercise. And I think you should look at the patient's minutes of physical activity as a vital sign. We call it in our system at Kaiser Permanente an exercise vital sign that's asked of every patient. And we know that the recommendations for physical activity are 30 minutes of a moderate exercise like a brisk walk on 5 or more days a week. And it shouldn't matter what your specialty, the specialty of the provider. If you're taking care of living patients, you should be assessing exercise and making an exercise prescription. And I think at the end of the day, we need to merge the fitness industry with the healthcare industry. And I think the exercise vital sign is an essential first step in that. We've been using it at Kaiser Permanente since 2009. We've integrated into our electronic medical records. Our medical assistants, as they're rooming the patient, ask them about their exercise habits, and they record it into the chart. We use the EPIC electronic medical record, and you can see right up under the traditional tabs of the chart underneath vital signs, the traditional vital signs, we have a tab for exercise vital signs. So after the medical assistant measures blood pressure, pulse, temperature, they ask the patient 2 questions. On average, how many days a week do you do moderate or greater exercise? They then click 0 through 7 based on the patient's response. The follow-on question is, on those days, on average, how many minutes do you exercise at this level? And obviously, we're looking for adults to be doing 150 minutes or more of moderate or greater exercise. And those who are not doing that amount of exercise are flagged with a best practice alert, which reminds the physician to simply counsel that patient on their exercise habits. We're looking just for a sentence, either, hey, good job, you're doing 150 minutes a week, keep it up, or today I notice your blood pressure is high and you report you're doing 0 exercise, you need to change that. The simplest thing we do is offer a walking prescription. The treatment for your blood pressure today are to lower your blood sugar. So I'm not going to put you on insulin, I'm going to put you on walking 30 minutes, 5 days a week. Let's at least start with that. I think that has to be a starting point for all of us. So in summary, I suggest, in my mind, the evidence suggests that you can outrun a bad diet, and we should be encouraging all of our patients to do so, and encouraging them that even if they don't lose weight, they're going to get the benefits of exercise, because multiple studies have shown us that you're better off being fat and fit than skinny and unfit. And for this reason, I think the promotion of physical activity should be at least placed on equal footing with weight management as an imperative to good health. And I think to do this in the clinical setting, we must begin using an exercise vital sign or physical activity vital sign to assess every patient's activity habits and giving them a proper exercise prescription. And lastly, those of us in this room, I think, need to lead this. And if you think about the intersection of physical activity and health, it lies closest to the specialty of sports and exercise medicine. And if we don't lead this idea, no one else is going to do it. And I hope that you'll come away with this with the motivation to do that. Thank you very much.